tube them, get it done, get that tube in, and go. We actually ran into a lot of pushback when we started slowing it down quite a bit. We started looking at the science of it more. Things change, things are always changing in this business, and you look and you realize, hey, we're not doing this the right way. There's better ways of doing it. We're causing more injury to the patients than we should be. So we slowed it way down, which is why we decided to take the word rapid out of this. So what are we going to talk about? Define what it is. 7 P's, you'll listen to those in a few minutes. Talk about what pharmacologic agents you're going to be using or you are using. And talk about controversies, concerns. I do have some questions that were forwarded to me by JD. Anything you guys want to talk about, it's fair game. So what is it? You guys can read it. Basically, it's a virtual simultaneous administration of sedatives and a neuromuscular blocking agent called paralytic agent to induce the paralysis of the patient for a safer intubation, safer management of that airway. This is a big thing here. This can be very harmful if it's not done right. Again, why did we slow it down? Turns out we, and when I say we, this is on film, I don't mean me specifically or our people specifically, we as a group were harming people. We were doing it wrong. We were causing injury. Hopefully in discussing this today, you'll kind of get an understanding of why that is and what we were doing, what we're doing better now. So who's going to perform this? And this is straight out of the Lord Fairfax protocols. Paramedics are, you have to be a paramedic with 2 years of documented experience as a cleared provider in the region. Go through a training program, passing score on a test. I don't know what you guys are using as a test. I'm not part of that. Authorization by the OMD and continuing education as well as skills verification. Is that still every 6 months you're doing? Okay. When are you allowed to do it for the protocol? When the patient condition warrants it, it's a great term. That's when we do everything right. And don't give them a drug they're allergic to. And when you've requested air medical services. Now keep in mind this is written for the region as a whole. If you're down the block from the hospital, don't wait for a helicopter, please. I'd love to fly, but there's just something you should do. And again, if you are practicing other areas, other places in the region, also remember that inability for air medical services to get there is not a reason to not do the skill. You're supposed to be requesting it to get, for a couple reasons. One, get people there who've done this skill before, and also to move that patient. Once that patient's intubated, what do you gotta do for them? You gotta breathe for them. What is it being carried? Vents. So, in a perfect world, that patient needs to be immediately on a ventilator because none of us, not a single one of us, this has been proven time and time again, can bag worth a damn. It's just, we don't do it well. We can get the best bag out there, we can have, PEEP valves on, we can have, look at our pressures, we're just not gonna do it well. So why bother with it? What is the point of actually doing this? Probably shouldn't use the word rapid in there. Airway control. We're going to control that airway. We're going to have a lot less risk of aspiration. We're going to have higher success rates than trying to muscle a tube in on someone who's just been sedated or has other things going on. And it's optimizing conditions. When you walk into, how many people here have been intubated in an operating room during clinical rotations? Great. That patient is what? They're heavily sedated, they are paralyzed, they haven't eaten for at least 8 hours, they're dry, they're on a table in front of you. The first time I remember the first time I did an OR rotation. Now because that should sound foreign to all of you. That patient is the perfect condition. First time I did that in an OR when I started flying, I'm like, I can't do this. I walked up to the patient, I got in there with the laryngoscope, and I'm like this. And the anesthesiologist was like, what the hell are you doing? Stand back, like, stand up, stand back. I'm like, this is not how we intubate. Put them under the table, turn off the lights, start screaming like something on fire. And I got this. I can't do this with a patient at like chest level and good conditions. We're going to get as close as possible to those crappy conditions that are supposed to be perfect for you. So what are the problems with intubation when we're normally doing it? Now, when I say normally, here's the problem. Most of us, before using or having access to the medications, when do we intubate people? Cardiac arrest was pretty much it, right? So it's crash airways, you're running a code. You weren't all that worried because bottom line is, if all the people you intubated in your career, you're lucky if 10% of them were gonna live anyway, right? I mean, this was like, I'll get a tube in them, but whatever. And then what did AHA start coming out? And the ACLS folks said, yeah, you don't really need to intubate them, unless you're gonna move them. Just learn how to do BLS better. We're moving these patients, and we're taking patients who are critical, maybe awake, maybe not, but breathing on their own to an extent, and trying to make them better. So what are the problems we're gonna have? You have bronchospasm. If you're trying to intubate someone without agents, bronchospasm is huge. Increased intracranial pressure, why? What's causing that? You're jabbing in the back of the throat with a tube. And you're gonna have a massive increase in catecholamine, which is actually going to be, for that critically ill patient, you're wiping out any reserve they've got. Now, think about the ICP for a second. So cerebral perfusion pressure. Does anyone remember the formula for CPP? It's their mean arterial pressure minus their ICP. If their ICP goes up because you're jabbing them in the back of the throat with a tube, their cerebral perfusion pressure is going to tank, right? The higher you're subtracting that higher number, you're not getting blood to their brain. So that's of every reason we do this. That's tops. What are we trying to protect? The brain. If you can keep that cerebral perfusion pressure low, the ICP low, you keep the perfusion of the brain. Okay. Couple things that we run into that are downsides and things that we can control with MAI. Again, we just talked about intracranial pathology, cardiovascular disease. Again, let's not take these patients that are already compromised and put them under more stress. You take the body, you sedate them, you paralyze them. You have now taken all that stress away from the body. You're in control now. And those patients with really horrible lungs, when you're intubating them, it's not necessarily the problem. You have, unless it's a very tight upper airway. But your issue at that point is you can get that tube into them. That patient who can't breathe, who can't handle their own respiration and ventilation, get a tube into them under controlled conditions, keep them heavily sedated, get them on the ventilator, and you can control a lot of things. You can take those really sick lungs and turn them around with the right vent settings. Here's some things that we're gonna always see, always assume we're gonna see, and hope we're gonna see. Patient got a full stomach, we're gonna make that assumption right off the bat. All right? So what do? The patient starts throwing up? Point him at your partner, exactly. In my case, that's always the nurse. So. Love you guys. Yeah. You need IVs, preferably 2 of them that are running well. We've gotten into a really, what I consider kind of a dangerous place in starting IVs. People have gotten real lazy. The IO gun, people go, like, IV skills are dropping. Don't go straight for that gun. I mean, if you need it in a real rush, truly, that's one thing. But keep your IV skills up, please. Don't just keep drilling these people. Yes, they say it's just as good as a line, that you can flush stuff through it. I'd rather have a good line than a good IO. Right, 2 of them. Pre-oxygenation, we're gonna talk about that. You're gonna be using a combination of, depending on the patient, non-rebreather or high flow, nasal cannula at high flow together with the non-rebreather. If they're not breathing well on their own, obviously you're gonna need to bag them, but even with that bad, nasal cannula, high flow, and we'll talk about that. You want a cardiac monitor and pulse ox, and you wanna make sure your end tidal is prepared. You guys have, and I apologize for not remembering the answer to this, you guys have mainstream or side stream monitoring, or are you just using the easy cap, the litmus paper?
No, we have a cap.
Inline, okay. Good, because actually seeing that waveform is huge. And those disposable things, 2 breaths, they expand, they're horrible, they're useless. We carry them, I cannot remember the last time I opened one, it's been years. Try and avoid the BVM, why? It's obvious, I think. All you're doing is pumping air into their stomach unless you're doing it perfectly. So you're gonna make it harder for yourself. You're going to encourage that patient to throw up. If you can keep that patient's sats up over 90, hopefully closer to about 94, just with that high flow mask and the nasal, that's your go-to, okay? You can always use Selleck's maneuver. Anyone not know what Selleck's maneuver is? The guy with the mustache, obviously. Has a mustache like JD?
Yeah.
So remember Selleck's maneuver. Theoretically, that is going to help you avoid aspiration and make sure your suction's working and ready. Let's talk about what we're about to do. This was a concept that was brought to me during a difficult airway class several years ago, and I think it really drives a point home that people don't think about. That is the same as that. Okay? You are killing the patient. All right? You're giving that drug, that's a neuromuscular blocker, a paralytic. Their diaphragm's not going to work anymore. They're not breathing. Congratulations. So think about what you're doing. What I want you to think about is, you want to ask yourself questions. Is there any way I could avoid giving this? What's going to happen to the patient if I don't do this? What's going to happen to the patient if I do this? What happens if I can't get the tube? What are my backup plans? I want to know my backup plan, and I want to have it ready. It should be out next to you for when things go sideways. Assume this is going to go sideways. And is there anything else I can do other than give this medication? If the answer is yes, do the other thing. We were just talking earlier, we used to walk around and intubate everybody. Everyone got tubed. If I could come up with a reason to RSI you, damn it, I was doing it. That was a cool skill. I get to take total control, I get another tube, great. It's stupid. There's just no good argument for doing that. Probably the best thing we have in the toolbox right now to avoid having to do this to a good number of patients is your CPAP. Okay? Those patients that were those real tight airways, those real tight lungs, who you sat there, or the patients going to heart failure, those ones who you sat there and go, I have to take this airway. CPAP is great. BiPAP's better, CPAP works. Again, especially since you guys aren't that far up in the hospital. If you can trial them and get them there, do it. That said, don't be afraid of the skill. Know it, respect it, and know that there are options. So earlier on, there was talk about 7 Ps on the first slide. What are they? Preparation, and that is getting all your equipment, getting all your medications set, double checking your medications, having your backup plan out and ready to go. What are your potential backup plans? King Airways, your first one. Craig's and Craig's up next. Okay. You guys have been through Craig lectures. It's always good to review it. I'll be the first one to admit, I teach the Craigs. I have done one Craig in my career, and it was a needle Craig and we'd go into a vet school, and they would have sedated animals. We sit there, and those things have long necks. You could do crike after crike after crike on it. I've never had to do it in real life. The one time I did it was needle, like I said. I rolled into a hospital with this patient by ground, and a medic who had been, I don't know, his paramedic number was like 1. He'd been around forever. Guy looked at me and went, he goes, oh my God, he goes, that's a 20-minute skill. I kind of want you to turn off of this one, but he goes, that's a 20-minute skill. I go, what the hell are you talking about? He goes, it takes you 19 minutes to do it, and then 1 minute to actually do the skill. He goes, it should scare the hell out of you. You know, you're about to start cutting on someone, sticking a needle through someone's throat. But okay, so preparation for oxygenation. You can't start that too early. If you think you're going to have to do this to the patient should be on oxygen already, right? I mean, if you're going down this road, that patient should already be on oxygen. Turn it up, put that nasal on, crank that nasal up to 15, all right? We were always taught nasal cannula goes from 2 to 6. God, you never do it any bigger. You're going to have their nose flapping around their ears. Flap away. Turn that up, crank it up. You want to have that air movement in the upper airways. It actually will move things for you, okay? Pre-treatment, we're talking about sedation at this point, potentially analgesia as well, depending on the patient. Paralysis, placement of the tube, protection and proof of placement. What does that mean? Securing your tube and making sure it's in the right place. There's absolutely no crime in missing a tube. We've all missed tubes. If you haven't been doing this long enough. The crime is not realizing that it's in the wrong place, okay? And by the wrong place, I don't mean, I'm a little bit right main stem. It's in, all right? I'm not a big fan of starting to sit there and go, again, when you're not dealing with long-term care, let me pull it back a centimeter and listen again. Let me pull it back another centimeter and listen again. As long as you're not blowing massive pressures, you're not worried you're gonna pop a lung, be happy you got the tube in there and get the patient where they need to go. And how are you gonna do that? You're gonna have that patient on your end tidal. That's the #1 thing to me. Other than watching that tube go through the cords, end tidal is gonna tell you so much about that patient's status. You know, listening, great, fantastic. End tidal is prime, okay? And every time you move that patient from spot to spot, get them off the ground, put them on the stretcher. Listen again, double check that end tidal. When you move them into the ambulance, you're jostling that patient around. You know, trust that you know how to secure that tube. Always check. You know, trust but verify. Trust yourself, verify yourself. You're trying to move that patient. So this is an approximate timeline of how this is going to work. That's a big number. You got a patient who's going down the crapper. That's a big number. Again, we used to go, give them the drugs, get the tube in. We weren't pre-oxygenating correctly. We weren't keeping these patients safe. So start getting going. Get your equipment together. Get that oxygen on them. Before the pre-treatment, again, get those initial medications on board. Give them time to work. You don't want to slam it. This isn't like working with adenosine, all right? You're not going to slam the meds in and hope they take effect like that. Pre-treat the patient, watch the patient. You do not want to give a paralytic to a patient who is not properly sedated, right? Think about if it's you and someone were to give you a paralytic. Paralytics don't put you to sleep. They just stop you from breathing and moving. So you're wide awake, wondering what the hell's going on, and can't breathe. So, I mean, large amounts of sedation before you even think about getting a paralytic near a patient. And again, this is an approximate timeline. No one's sitting there with a stopwatch. You guys, I don't know what checklist you're actually using. I put this in kind of before this was all rolled out to the region. But there's, you guys have a checklist with your stuff, right? Mm-hmm. So it probably doesn't look exactly like this, which is fine. It's gonna have all the same major points. Oxygenation, patient don't try and do this with a C-column replace, all right? You're just setting yourself up for failure. It's okay to take a collar off a patient as long as someone's securing that for you and holding it. We'll talk about the assessment of the airway, vascular access ×2 we talked about, the ability to monitor your patient. Again, make sure your suction works. Nothing worse than getting in there and realizing I can't see anything and I can't fix it. All right? We've all intubated through stuff that we couldn't see. We got lucky. Your end title. This is kind of old. This is old. This is like pre-fiber optic. Just make sure your batteries are good. For those of you who don't know, you just actually screw the light bulb in and make sure it works. Make sure you have an ET. Here it says stylet. Bougie. Use the bougie. There are people who think it's only good for, or should only be used on difficult airways. Assume every airway is difficult until proven otherwise. And it's just good practice. Use it. I don't care how you use it. Some people like to preload it, use it almost like a stylet. I'm not a big fan of that personally. I just think it's cumbersome. For me personally, I tend to take, we have the really long ones, some people have the shorter ones, but I'll put a twist in it so it makes it shorter, so I don't have this big thing flopping around and you don't really have control over it. Whatever your technique is, use the bougie every time. With that technique, you'll get used to it. It's a great tool. I will tell you, the first time I used the bougie was on a patient who was probably every bit of 350, 400 pounds. Was a horrible airway. We had just gotten them. I had not practiced with it. I literally looked I couldn't remember what it was called. I looked at my pilot, I said, get me the blue thing out of the bag. Hands me the bougie, I go in, I can't see anything. This is the worst airway I've probably ever seen in my life. I just ran that thing as high, as anterior as I could, pushed it in, and I felt like little ridges. Went, holy crap, they weren't lying. They were actually in there. That's awesome. I then took it and pushed it as far as it would go. Like, I'm gonna right main stem this thing, I don't care. I'm not losing this thing because this is my only way I'm getting this tube, because I literally could not see the thing. And got the tube, but practice with it. And again, have your alternative airways ready. Syringes labeled. I know we label syringes. It's kind of important. You don't want to give the wrong med and in the wrong order. Calculate your doses. Have your partner double check them. I mean, this is huge for us. Again, I kind of have that feeling if you haven't made a medication error in your career, you haven't been doing this long enough, you will. And it's, depending on the medication, it's really scary. Hey, I gave a little too much Narcan. Fine. Hey, I just gave the wrong narcotic. Oops. Always have your partner look at it. You are going to run into what you think is your standard dose, your standard concentration. And this is probably the biggest place where people get messed up. Pharmacies giving you the same concentration time after time after time. Hey, wait, there's a shortage. We can't get that anymore. We need to substitute this other, same med, different concentration. I'm used to pulling up 2 cc's or something. Now I need to pull up 10, or vice versa. So just be careful with that. We're going to talk about ketamine. We'll talk about rocuronium versus vecuronium, and then again, post-intubation care is going to be lots of sedation. It's very rare that you need to reparalyze the patient. There are occasions where you do. You always have to restate the patient. This is just kind of a different version of the same thing we talked about. But it does show you, this shows you with the medications. Fentanyl, I believe it's in your protocol. It's not a must-do. It's a do it if you need to. Remember that your sedative is not analgesia. Okay, you're looking at 2 different classes of medication. Now, ketamine. That said, ketamine is a dissociative medication. So while it's not an analgesic, it's associative, which means you can bonk the patient on the head with a hammer for a while, it'll hurt, They just won't know it hurts. Okay? Also, don't do that. So just remember that if you have a patient you feel needs pain management, you've got fentanyl for that in your protocol. We'll get into the meds shortly, but ketamine 2 milligrams per kilogram is going to be pushed over 1 to 2 minutes, followed by your rocuronium, and you're going to follow it up with the continued sedation. Prepping the patient, again, we already talked about this: monitoring, access, positioning. This is all difficult airway stuff that we'll get into in a moment. For you guys, you're supposed to have 2 paramedics when there's RSI credentialed. I don't know internally if that's what you're doing or if it's what's available. You know, I'll do that as an internal conversation for you guys. So what are all those things that were on the other one? So the 4 Ds: distortion, disproportion, dismobility, dentition. So do they have something blocking their airway? Do they have, you know, is there something traumatic going on? Does their face look the way it's supposed to? Is there blood? Is there vomit? Is there something basically blocking your entrance into getting this thing done? Dentition. Scariest airway. I talked about the most difficult. That was the 400-pound guy. Probably the scariest airway I had was a guy who weighed probably about 110 pounds, tall, skinny guy, going for a lung transplant. I was on a fixed wing transport with this guy. Had enough oxygen that I should have been able to go from one side of the country to the other with him. I was going 2 states away. This guy, for whatever reason, was just sucking down on his BiPAP, was just going through oxygen like mad. He had 2 front teeth that were like, I mean, overhanging. This guy could have taken down logs. Like, I mean, it was amazing. Could have chewed through anything. But the problem was he had a really small mouth and giant front teeth. If I had to intubate this guy, I have no idea how I was going to fit a blade in his mouth to do it. This guy literally may have been a straight crank patient if I needed to. His airway was that frightening looking. Disproportion. This guy have no neck, just very large. And what was the other one up there? Dismobility. This guy, do you have a patient with C-spine issues? Do you have a patient whose head you can't move and put in the right position? And again, the different mnemonics are there. They're all kind of talking about the same thing: bones, beard, obese, no teeth. I don't personally know why that's an issue. I think that's fantastic. It's everything out of your way for you. Old people that snore. Again, just same obvious types of things here. Malempati, I don't know if you're familiar with it. It's just a way of grading your airways. You want to have that patient sitting up. So again, not every one of our patients can do that. But to get a true Malempati score, they need to be sitting up, looking at you, open up and say, ah, that's what you want to see. This ain't bad. This should scare you. This one, it's time for another career. Just don't bother. This is like that patient I talked about with the bougie the first time I used it. You just couldn't see anything. And that's more of a realistic view of it. That's like neon lights going, tube me, tube me. And this is, yeah, not going to be a good day for anybody. Poor dentition. Went to intubate that patient and went, holy crap, those are fake. Someone had those made. There's no way you should have any expectation looking at that patient's mouth that they've got dentures. Went to intubate the patient, stuff started moving. Like, my God, someone actually paid money for that. That's awesome. There were comments about them being family heirlooms or hand-me-downs. Yeah, that took us all by surprise. Cormac Lahane, this is very similar. This is just another way of looking at it from Malempati. Again, grade 1 is what you want to see. Grade 2, that's not a bad day. This, get that bougie out, go anterior with it. This, see if you can get it. This is a good time for a king airway. You know, try that. If which is, anyone know that, the fingers in the mouth, underneath, yeah. So, remember, it's the patient fingers, not yours. Mal and Patty, we just looked at, that's 1 and 2 are fantastic, 3 and 4, you're gonna worry about. Are there any obstructions, and can I move this patient neck? What are my choices for rescue airways? We already talked about this. You got your king, you got your steel. There's gonna be times where you go, I'm not even gonna bother tubing this patient. I'm going straight to something that's a backup airway. There is absolutely nothing wrong with using that. I'm lying, you should always try to tube first. No, I mean, there should be no stigma, no shame to go into your backup airway first if you need to. We'll just make fun of you later. You gonna try and tube that patient? Or are you gonna go to a backup airway right away? This patient, by the way, sitting up, maintaining their own airway. If you need to tube them, if it's me, I'm gonna look for the bubbles. Yeah. That's exactly what I'm gonna do, look for the bubbles. This is where MAI is gonna go bad on you though. Okay? If you try to put the medication on board with this patient, you're gonna lose any chance of getting that airway without going surgical. It's not gonna happen. Yeah, have your suction ready. And this may be the day you go, the only thing I can use here is steel. I'm going for crank. So why are you gonna interrupt your attempt? Any one attempt going past 30 seconds, everyone knows it's the old 30 seconds from first breath to next, last breath to first breath. If your patient just starts looking like garbage, you look at that patient and go, wow, they've got no reserve, they become cyanotic very quickly, their color changes very quickly, stop, get that oxygen on them, bag them back up if you have to. Any change in heart rhythm, this patient should be on an EKG monitor before you do this skill, all right? What's gonna change, hypoxia will do things to the heart, obviously. You see a change in their rhythm, that should worry you, that patient's not getting enough oxygen. And obviously, if your end title says they're becoming hypoxic. So pre-oxygenating them, what are we doing, why are we doing it? Again, you're giving that patient that reservoir to use during that apneic period. Remember, you're stopping them from breathing. They need something to fall back on. Those patients who have really sick lungs, who have no reserve, are the ones that should scare the hell out of you. Okay? No matter how much oxygen you give them beforehand, the second you take it away, they just tank. Okay? So really pay attention to what kind of patient you're dealing with. If they are spontaneously breathing, we talked about get that non-breather on them, and avoid bagging the patient if you can. I've always kind of had the 8 effective autoplasty breaths. I mean, if that's all you have is the ability to bag them because they're not moving air on their own, that's great. Use it. It's not optimal. We talked about the nasal cannula. This is best practice now. You're going to see it hopefully anytime you see the skill being performed. And until you know that that tube is good, that nasal should stay in place. Keep that oxygen flowing, keep that reservoir there. Okay. Fentanyl, again, it's choice for you in your protocol. If you feel the need to use it, it's there. 3 mics per kilo, slowly by IV. Just be careful if you have a patient who, you're using this for pain control. Who's gonna need that? Traumas. However, if you have a patient who is basically just blowing through, has massive catecholamine releases, and now you start giving them the fentanyl, you can actually knock out whatever they've got left. This is straight out of, like the PDR and the insert for the medication. I always love these drawbacks, respiratory depression, that's actually not too bad for us right now. We're okay with that. That's exactly what we're going for. Nausea and vomiting, it's usually not immediate onset, so you're gonna have a tube in place before it's an issue. The muscle rigidity is where people talk about like the chest wall movement. I've never seen it happen personally. It's in the literature. You'll have people swear it happens. I've never seen it. And I think you really need to get quite a dose if you're gonna deal with bradycardia from it. It used to be atropine. Everyone remember, every kid that everyone gets atropine when you intubate them. What was it for? It was theoretically for kids, but we found out it was garbage. It was being used to keep the heart rate up. But what causes a decrease in heart rate? Hypoxia. Guess what doesn't help hypoxia? Atropine. What helps hypoxia?
Oxygen.
Right, so forget about atropine. It was also used in adults getting the second dose of succinylcholine. You're not using succinylcholine, don't worry about it. So here are the meds you're going to be using. Ketamine, 2 milligrams per kilogram. Rocuronium, 1 milligram per kilogram. Are you guys doing strictly rock, or are you using Vec as a backup?
Rock.
Okay, great. So rock it is, 1 milligram per kilogram. Has anyone here used ketamine yet? No? Okay. Awesome drug. Again, it is dissociative, which is kind of a cool thing about it. It's basically in the same family as PCP. So if you think back to years ago out in LA, Rodney King thing, why could he they kept beating him and he kept fighting? He didn't know he was getting beaten, right? Your brain is just shut off from the rest of your body. It's a general anesthetic, so it's just totally dissociating the brain. One thing to think about with this though, ketamine needs to be given in small doses or big doses. The middle range gets you in trouble. Everyone's heard of the K-hole. You have people reemerging from ketamine dosage who just don't know what's going on around them. It'd be very dangerous for the patient. It'd be very dangerous for you. While ketamine is given as, some medications are given actual by weight, some are given by ideal body weight. Ketamine is given by ideal body weight. That said, I would argue that you can't really give someone too much ketamine. Okay? This is not something, you're looking for this patient to be sedated heavily. You're just going to sedate them longer. I'm not saying you should overdose your patient on something, but we're going to err on the side of more ketamine than less ketamine. It's a fairly quick onset. Keep in mind, of all the medications you've given throughout the years of practice, the paperwork always says your onset is between this and this. You have patients who you give like a sniff of something and they're out. You have other patients who you give the same medication to, and 2 minutes later you're looking going, what? Nothing's happened. Remember that every patient's different. This is a generalized number. What are our contraindications for the drug? I always like that one, hypersensitivity. I don't know what hypersensitivity ketamine is, especially when you're trying to knock your patient down. This is a big one. You can have an initial spike in blood pressure and ICP with ketamine. We do carry etomidate for those occasional patients that we're worried. But for me to even think about that, I'm going to have that patient who I know has a head bleed. It has that pressure that is just sky high. Other than that, I'm fairly comfortable giving ketamine to just about everybody. And you're not going to be using this on patients less than 12 years of age or 50 kilograms. Side effects, again, I don't consider all these side effects. I think they're good, some of them. The delirium and vivid dreams is the problem. You don't want the reemergence from that. Keep them sedated. Once you're giving ketamine, keep giving ketamine. Damn hypersalivation. I hate that. If your patient starts drooling a lot, you're fine, don't worry about it. Again, respiratory depression, we're kind of going for that in the long run. So where can it be given? If you're dealing with pain control, you're going to give low dose emergencies, again, are you guys currently using it for that? I don't remember what the protocol is. Okay.
Exactly that.
So 3 milligrams per kilogram IM, up to 150 milligrams a single dose. It's very effective, right? And again, low dose for, if you're using it, along with analgesia, we're going very low doses of this. And it's very effective. I gave it to a guy who I needed to, basically reduce a leg fracture on him to fit him into a helicopter. I think I gave him 10 milligrams times 2 over about a 5 or 8 minute period. Moved his leg. Guy screamed louder than I ever heard in my life. I apologized to him, and he didn't know what I was talking about. I said, dude, I'm really sorry, I just did that. He goes, did what? All right, it works. And again, you want to give it prior to the paralytic. Very important. 2 milligrams per kilogram of ideal body weight. Don't just look for the 30, 40 seconds. Watch your patient. Watch what they're doing. That patient starts losing muscle tone. You sit there and go, okay, or you can't wake him, you can't rouse him. Great, now you know you have some good sedation going. Couple types of neuromuscular blockers. Depolarizing and non-depolarizing. Succinylcholine is depolarizing blocker. It basically just dumps everything, and you'll see that patient actually start to shake. You'll see fasciculations. Rocuronium is not that kind of medication. You will not have that visual clue of fasciculations when you're giving the patient rocuronium. What you're looking for is really, you give the medication, you keep that oxygen on them, you're waiting, just test their jaw. If you can just take that lower jaw and it just starts going, you know you're good at that point. Be careful. Remember, it requires refrigeration. You're giving it 1 milligram per kilogram of ideal body weight. Remember, I'm not ideal body weight, all right? But I should get that medication based not on my current body weight, but what I should be, which apparently is, I don't know, about 110 pounds.
We don't have any charts or anything like that, so what would you recommend?
Well, I would recommend, I don't think I have it in here. Hold on. I don't remember off the top of my head right now. I am completely blanking on the formula. There is a formula for ideal body weight. My suggestion is just look it up. Have that. I would have that on a card along with your checklist. And it's different. It's different for men versus women.
John,
yeah,
the hand
just-
levies will take that place, right?
What's up?
John,
What's that?
the hand levy,
Kentucky.
levy, is that gonna,
Everything should be.
So there is a formula for ideal body weight. Again, it's approximate. If you give a little bit too much, you can't overly sedate or overly paralyze this patient. Just remember that. So
Ideal body weight for men, 50 kilos plus 2.3 kilos times the height in inches minus 60.
yeah, what he said.
He said look it up. I looked it up.
That, again, you're not going to overly sedate or overly paralyze the patient. What are our potential problems? Not having a good neuro exam prior to giving it. If you have that patient who's now paralyzed for a half hour, 40 minutes, and you roll in with a neuro patient, and the neurologist wants to examine the patient, he's gonna get really pissed at you. Failure to sedate, remember sedation. Inadequate dosing, again, I'd rather have a little more on board than a little less. Aspiration, dysrhythmia, I don't know that I've ever seen a paralytic actually cause a dysrhythmia in a patient. If there's been dysrhythmias in conjunction with this, it's probably because there's hypoxia involved as well. And again, always be prepared with a backup. I can't say this enough. Okay, continued sedation. You will likely not need to re-paralyze your patient. This, again, couple reasons. One, proximity to the hospital for you guys is probably the #1 reason why you won't have to re-paralyze. We rarely re-paralyze a patient reparalyzing them, it's because there's some issue where they're bucking that ventilator regardless of sedation. I see pressures start to increase, regardless of sedation. And in those cases, I may choose to reparalyze my patient. It's rare. Usually sedation by itself is enough, and you want to keep that patient sedated the entire time. Right? How do you know when it's time to resedate your patient?
Start getting a little tachycardia from the monitor.
They might start getting a little tacky, okay? Blood pressure might go up, but how often are you taking the patient's blood pressure?
5 minutes.
Every 5 minutes. So if they start becoming undersedated 4 minutes before you take that blood pressure, you're way behind the 8 ball on that patient. Your initial sign is going to be seeing that heart rate creep up a little bit. Try and dose them before that even happens. Sit there and say, okay, I've got ketamine on board. Should last me, hopefully, on an average patient, let's say 15 to 20 minutes before I need to redose them. So at 15 minutes, I want to have that drawn up, and I might want to start dosing them then. Right? You may have a patient who eats through, and I've had this. I've sat there and said, we carry plenty of drugs with us. I've had transports where I go, my God, they're eating through this stuff like candy. I don't know why, but their metabolic rate is through the roof, and they're sucking through these drugs. I give them something, and 5-10 minutes later, I'm giving them more. It's patient dependent. Start off with what you know the drug should be doing. You don't want to have that drug wear off, right? If it's a 20-minute drug, 15 minutes is a nice time to redose, so you're not having that dip and not having the physiological effects on your patient. If you start having coughs, gagging, seizure activity, again, make sure that you have that airway control. Remember, again, these drugs do not have sedative properties. They don't have anything to do with pain control, and they do not control seizures. Okay? The patient will stop seizing in front of you. You're not going to see them shaking anymore. You paralyze them. Seizure activity takes place in the brain. This does not stop seizure activity from happening. Okay? It makes you feel better about the fact that the patient's not seizing anymore. You've done absolutely nothing to help the seizure, and maybe making things worse because you cannot see what's going on with the patient anymore. So just remember that. So rock is what you guys are going to be using, also called Zemuron. It's paralytic. It's going to bind to cholinergic receptors and, felt sneeze there. Sorry. So binding to cholinergic receptors and motor end plate to antagonize the action of acetylcholine. What does that mean? I'm paralyzing my patient. Okay. You need to know how the medications work in your mind. I don't want you sitting there going, how is this working right now? What's the onset? 30 to 60 seconds. Watch your patient. Look at your patient, feel their jaw, see if it's relaxed. Once it's relaxed, you're good to go. 30 to 60 minutes, I'm going to say it's a 30 to 40 minute medication in my, in my practice, in my experience. This is coming out of the literature. Don't trust it. There's been billions of dollars spent on research to get that number. Do not trust it whatsoever. What's the indication? Being used to aid in the intubation. Side effects, hiccups, transient hypotension, tachycardia, respiratory insufficiency, and apnea. Like I said, it's a good day for us. We're going for that. It's all good. Give it over about 20 seconds. And again, I don't know if this is actually the supply you're getting. Do you know what you guys are getting from pharmacy? Okay. So make sure you're looking at what you're getting. Make sure it may change.
Yeah.
Is that it? Okay. Again, you can have a shortage. They could change it up on you without you even realizing it. So always look at your concentrations. Go back. So we've given the paralytic. We've got placement. You want to protect it. You want to make sure that tube's not going anywhere. You wanna make sure you have proof that it's where it needs to be. You wanna listen in all of your fields. Your end title, again, is your number one way of continuously monitoring that patient. The stuff we already talked about a bit. Get your suction ready, monitor's working. Make sure your tube works, make sure you don't have a big old hole in your cuff. Use your bougie, have your backup ready. Make sure you have someone there to help you. This is not something you wanna do by yourself. Alright, whether that person helping you is another paramedic, which is optimal, or not, or somebody to hold stuff for you. The biggest thing, honestly, you use that bougie, you get the bougie in there, you go, well, damn, someone put the tube on top of this thing for me? Alright, you want that extra set of hands with you. Pre-oxygenate, pre-medicate them, keep that nasal in place, get your meds going. Step back for a second, alright? There's a lot going on. We've slowed this down from being rapid to actually being more controlled. Just take a breath, think about what you're doing. You're gonna be, if you can relax yourself, the chances of this still going well are much higher. You don't wanna be that guy. Most of you probably know this already. What's the first thing wrong with that picture? Wrong hand fluid, exactly. Not gonna happen, right? Is anyone gonna have everything aligned perfectly every time in the field? It's nice to think so. It's not gonna happen every time. Self maneuver, again, just get that little bit of pressure there. This is hugely helpful. The backwards, upward, rightward pressure. You're looking for that tube, you're going, okay, I see it, I just can't get it to go where I want. That little bit of pressure, all of a sudden everything comes right into view for you, and you slide your tube right through. That's where you wanna start. That's where you wanna stop. Okay. Everyone knows what that is? Oh. Yes, no, maybe? Anyone not know what that is? Okay. Alright, good. How much should you try to do this? 2 attempts per patient, not 2 attempts per provider. Okay? Otherwise, you sit there and have, hey, I got 6 medics here, we can try this 12 times. Alright? And what is an attempt? I'll editorialize right now and tell you I don't agree with this definition, but it's a definition that is accepted industry-wide. You go through the teeth with that blade, that's an attempt. What I will tell you is, if you're through the teeth with that blade and you need the suction, keep that blade in. Look at what you're suctioning. Don't go in and blindly pull it out and blindly suction. You just wasted an attempt, and you can't see what you're looking at. You can't see what you're suctioning. Keep the blade in. If you can suction quickly and get that tube in, and you're still within your 30 seconds, great. And I would argue that most times, unless you've got something bleeding and gushing, that should not be a problem. You should be able to suction whatever you need out of the way and get that tube placed well within that time limit. Okay. I'm gonna let you read that because it's a lot. That's cut and pasted out of your protocols. So, everyone good with that? We already talked about verification. As I said before, unrecognized esophageal intubation is catastrophic. No harm in bad intubation, big harm in not knowing you did it wrong and not fixing it. These are just the ways we talked about. You can verify your tube placement. So what now? You secured the tube, you want to document the depth, we all know that on any intubation. Where is it? That's how you're gonna know if it's moved, right? So what happens now? Continued sedation and paralysis if needed. Like I said, rarely if ever will you need to continue paralytics on that patient. What am I gonna use to keep them down? Sedation, more ketamine. It works the first time, keep using it. If you need to, you can use Versed as well. Fentanyl, again, follow that up with a patient who may need the analgesia. these are the kind of things we shouldn't have to talk about, we always have to talk about. Always double check that tube anytime you move the patient. Sedation. Notify the receiving facility that you're coming in with a patient that you've done this to. And just, this is not your emergency, alright? Step back, oxygenate the patient, don't rush this. Rushing it is where you're gonna make mistakes. There's a reason you have that checklist, right? Use your checklist. This is going to be one of those, hopefully, low occurrence, high risk skills, okay? Utilize that checklist. You're not doing this every day to every patient. It's not going to become just, it's not going to become automatic. Think about the 7 Ps. And don't do that. I've got a couple of questions that were sent to me by JD that we'll talk about real quickly, and then we can review the case that you guys had and any other questions that come up. So first question that was sent was, what are some pearls you've gained over the years of experience as a provider practicing this skill? Treat the patient, not yourself, right? This is all about just take a step back, do what you have to do, don't rush it. When you realize that you're taking someone's airway away, your heart rate should be going up a little bit, all right? This is something that can go wrong. Remember that gun, do it slowly. And try and find a way around it. Like I said, if you can get that patient on CPAP and not have to do this, great. All right? If you don't have to take the patient's drive out from under them, don't. Are there any other medical conditions besides sepsis that would cause the patient to lose that critical balance or maintain in order to stay alive? The two things I would bring up other than sepsis are hypovolemia and any kind of injury that has a massive catecholamine release. So when you look at that patient that's barely hanging on, you're gonna have that urge and go, they're getting tired, they look like crap, I need to take this airway. Right? Slow down, and this is one of those things that only comes with experience. I had a patient, I don't know, it's probably 2 years ago now, who we looked at, and I mean, this patient just looked like garbage. And had I been newer, I probably would have immediately said, patient's gonna crash, I need to take this airway right now, gotta do something for this patient. They're just having too much, they're not gonna hold on much longer. My partner and I looked at each other and said, you know what, if we need to tube him in the helicopter, we can. I don't wanna lay this patient down, and I don't wanna take away what little drive they've got left. Got the patient to the hospital, they said, why didn't you intubate the patient? I said, because gut feeling is, this patient's gonna crash the second we try and knock him out. They opted to intubate the patient in the hospital. They crashed. We just turned around and went, hey, there's only so much we can do. If that was our opinion, again, had I been a newer provider to this skill, I very likely would have intubated this patient. Just try and look at the big picture, use your gut, use your clinical knowledge. Remember that you're gonna have a whole lot of doctors tell you you're a paramedic, you don't practice medicine. I practice medicine, you practice under me, you're an extension of me. In theory, that's great. In reality, you guys practice medicine every day. You're making the decisions out there on your own. You're given that autonomy to do it. So use that clinical knowledge and that skill that you've gotten built up over the years. Look at your patient and you may just have that gut feel. And again, those hypovolemic patients, that's another one where if you can't get them, if you can't replace something in there and boost their pressure before you take away their drive, there's a good chance they're gonna crash. It's very common before I do an RSI, especially on someone who's either unstable or who's very large. I'll give them a fluid bolus as long as their breathing's fine, I'll give them a fluid bolus, and I'll actually give them a pressor prior to intubation. A little tough for you guys to do. We have push pressures where I can just give them a little bit of epinephrine or a little bit of neosynephrine, but it gives them that little bit extra drive right before I take everything away from them. Remember also that once you get that tube into somebody, you know, we're not talking about that patient who's in cardiac arrest who it's not that big a deal. You're taking someone who's breathing, you're now putting a tube in them, you're introducing positive pressure into their chest cavity. What does that do?
Decrease cardiac output.
Was it?
Decrease cardiac
Yeah.
output.
You're decreasing their cardiac function at that point. You're putting pressure on the cardiac muscle. You're decreasing their preload. Right? You're now going to have pressure in their chest cavity. It's going to make it more difficult for fluid to get back into the heart. So think about fluid bowls before you do this. Give them a little bit something extra to work with. Prime the pump, so to speak, before you do the skill. If you think the patient has a chance to crash landing. Again, that patient might be hypovolemic, might be septic, or might just be so big that you sit there and go, the second I lay this guy down, everything's just gonna crunch in on that heart and not allow it to function right.
Is that the main reason for the fluid bolus, arbitrarily, that, because it is listed in the protocol, we give a fluid bolus prior?
Yeah, it's exactly the reason behind it.
Okay.
Yep. It's not, you know, if I have someone who I don't think is compromised in that way, or who's smaller, I'm not gonna do it on every patient, but it's there. Again, use your clinical judgment. As long as that patient does not have an issue, you know, they're not in failure, you're not gonna hurt them by giving them a fluid bolus. Give them a couple hundred cc's of fluid. It can be just enough to give them the boost they need before putting them down. Do you have a list of tips you can share for that challenging airway? Bougie, number one, absolutely. Start shallow and only go as deep as you need to. There's a habit, and I was taught this way years ago. Take that, you take the biggest blade you got, you stick it all the way down, and if you don't see anything, just pull it back, bink, there it is. That is the absolute worst way to intubate your patient. First of all, you're gonna drive their ICP through the roof. And if you really want to see, you know, that far into a patient, there's other issues. Start slow, just kind of little bites as you go in, and just kind of work your way in slowly. You'll get to the point where you need to be. There's no reason to go further. You increase the odds of a traumatic intubation by going too deep. And I will say, as someone who just had what was probably a side effect from an intubation when I had surgery recently, and something that who knows, maybe I've done this to patients myself, I don't know. I ended up coming out of surgery, and they thought I had just huge issues with my tongue. I had swelling of my tongue. They thought it was angioedema. Couldn't figure out why. It turns out there was an issue with my hypoglossal nerve, probably caused by a traumatic intubation. So I couldn't talk right for about 2.5 weeks. I felt like I was aphasic. Maybe they went a little bit too deep on it. I don't know.
Paramedics too.
I'm sorry?
Paramedics too.
Yeah. Yeah, exactly. So start shallow, only go as deep as you have to. Extra set of hands. Have someone to do that burp maneuver for you. Hand you things. If you have a difficult airway, if you're having problems with it, the last thing you want to do is start putting stuff down, reaching for things. Have someone there to help you. Have suction. Make sure your suction's checked out. Make sure it's working and it's on. And if you're having trouble getting the airway in, don't change. Always change something. Only change one thing. Okay? If you go in for a look and it's just not working, don't start from scratch. Sit there and go, I'm going to change one thing in my technique. Whether I'm changing the angle that the patient's at, I'm changing the size of the blade I'm using, I'm changing providers. Change one thing at a time, because if you do that, you'll know what the problem was. It'll help you if you can't get the patient intubated, you'll know I've tried this, and this, what's next. And it'll also just help you in future practice. Is this a skill that should only be utilized when you have no other options? Absolutely. useful do you believe this skill would be in our city limits, since we can usually have a patient in a controlled environment with a team ready within 10 minutes? I think you're gonna use it rarely. I think the times you're going to potentially use it are something like prolonged extrication, where you're not getting that patient out into the hospital immediately, and whatever the situation you guys were in the other night, we'll talk about that. Sometimes your patient's just gonna crash, clamp up on you for God knows why, and you just need that airway.
Location's gonna be key for us.
Mhm.
If they're on a third floor, they're a large patient, those types of things.
Absolutely, anything that's gonna keep you from getting into the hospital with an intact airway is when you're gonna look at it. Have you ever had issues with getting the desired results utilizing the drug regimen in our protocol? Yes, I have. We talked about this before, there's rare occasions where either just the airway just goes to hell on you, or you have that patient who just eats through those meds, that high metabolic rate, and you're dosing, you're looking at what your dosing is supposed to be, and it's just not working for you. So, just be prepared, anything, just like anything else that we do on the street, anything can happen. You have to be ready to just roll with the punches and deal with your patient. What are your recommendations for sedation after intubation as far as medication and timing? My answer to that is sedate early, sedate often. The biggest problem I've seen with RSI, MAI is undersedation of patients, and I haven't just seen it in newer providers, in people who haven't done the skill. I've seen it in hospitals, I've seen it on flight teams, I've seen it with people who do this all the time. Either they just shouldn't be doing it, or you get involved in other things. You've got the skill done, you've got the airway secured, you've got them sedated, you have them paralyzed, and there's 12 other things going on. All right, this patient's sick, they're injured, you're dealing with something else, and you don't remember to resedate them quickly enough. So, I don't know if you have to start, set an alarm, do whatever you have to do to make sure this patient is getting sedated before they need to be resedated.
Would you say the single best way to recognize it is tachycardia?
The first thing you're gonna see is gonna be that jump in the heart rate, yeah. So you want to get to it before that becomes truly tachycardia.
Right.
So,
See it start to increase.
and like I said before, I would rather do it before that.
Okay.
If you look at ketamine as a 20-minute thing, give it to them in 15 minutes. Don't let the dose come down immediately before it becomes an issue.
Wanna put the wagon up? You want our wagon?
What was it, sequel?
Yeah.
Evergreen?
Yeah.
Go to them.
Hey Ron, with that being said, the half-life of ketamine is documented for pharmacokinetics to be 5 minutes. So if there's no BP issue, wouldn't we be better off going straight to Versed because of the half-life of it being up to an hour? Being a longer, because my fear is that we're giving it, I think, 3 minutes, the ketamine 3 minutes before we start intubation.
Right.
So once we intubate, we only are actually looking at 2 minutes if we go off of the minutes they're suggesting.
Yeah, I don't know why it says 5 minutes. I mean, I generally look at ketamine as lasting about 15 to 20 minutes.
15, okay.
Yeah, so that may be a typo in the protocol.
It's not like that long. Fentanyl's gotta be given 3 minutes before your neuromuscular.
Well, I was just saying, because nothing we do is fast, I was just saying 3 minutes
Well,
hypothetically.
But you're supposed to give your fentanyl 3 minutes before neuromuscular, and then you're gonna be waiting somewhere between 40 to 60 seconds after you give your ketamine to give you neuromuscular, so you're probably only looking at about a minute and a half, 2 minutes before you should be able to start.
Yeah, your ketamine's gonna last longer than that. Your ketamine's gonna last 15 minutes.
That really doesn't make sense, because down here for your redosing, it says 10 to 15 minutes. Why would you do 10 to 15 if the half-life is only?
Mhm.
It's probably more. 5 years ago.
Sometime last night, yeah, it's now
He's had it sometime in the last 12 years. This could be relevant information or not. Any other questions before we start talking about the case you guys had?
We see a lot of reference to SAT.
Yeah.
In truth, if your patient's severely compromised, how much stock do you put in that?
I'm gonna shoot for, before I do anything with that patient, I'm gonna shoot for that 94 or 95% if I can.
It's accurate.
If it's accurate. Now, yeah, if you have a patient who's shut down, they're shunting everything, and you can't get a legit sat, all you can do is pre-treat to the best of your ability. You know, you're gonna have, you know, you have providers who go with cookbook medicine and said, the protocol says I can't do this until I have their sat here.
Right.
There's gonna be patients that you could bag all day long and not get their sat above 72. You're not gonna not treat that patient, okay? So you, again, clinical knowledge, use your experience on that.
I rely on patient capnography through things.
Yeah, I mean, capnography is, in my opinion, the single best tool. If I had to pick one tool to look at what is that patient's status, it's
And
gonna,
as far as monitoring too, that's gonna give you continuous, so
absolutely.
your notes on.
Yep. So one of the things that we do is, and it's done strictly for educational purposes. I'll have the crews, we'll if we RSI somebody, we'll spit out the data from our Zoll and look at it in what the real-time data was, and you'd be really surprised if you sit there and you're bagging the patient, or you're pre-oxygenating the patient. You know, okay, we're great. We're at 98%. Everything's good. The drugs are on board. Go. And you got the laryngoscope in there. You're looking at your landmarks. And you take a peek up, or your partner's looking at the monitor, and your sats are great. You're like 95, 96, 94. You're still good. You're great. You're great. Get the tube in. Start bagging them. Great. You spit out that. Remember that your monitors, your SpO2 is lagging to begin with, and as you know, one monitor may be a little bit better than another monitor. What you find when you spit out the raw data is that patient may very well have dipped to the mid 80s, but the algorithm that your monitor's using just didn't spit that number out. You never saw that happen. You'll swear that patient was never below 95.
It's reactive data, where Encadol is proactive data.
Yeah. But again, while you're in the process of doing the actual intubation, the number you have to work with at that point really is your SAT. And it may looking at that raw data afterwards, again, not for anything other than individual education. So you can go, okay, this is what I swear I saw. And you're right, that's exactly what you saw. But what's really happening to your patient, and is there anything you should change next time to try and avoid that from happening? Or you can go, wow, okay, that patient was compromised, that makes sense. There was no way I was gonna not have that happen. But it's really good to look at just from a self-education standpoint. So something you guys might wanna consider doing.
So, for your sedated, unconscious patient there, we just made unconscious, we're worried about seizures. So how are we gonna tell if they're having a seizure?
Were they having seizures before they made them unconscious? There's no reason to assume they're gonna have seizures afterwards. If you were there for a patient who is seizing, that's a different story. And you should be treating those seizures as well as the airway.
So that patient would be better off to resedate with Versed.
I don't know what you guys use for seizures right now. I don't remember. Is it Versed? I would say Versed is a good drug to use for that point. Absolutely.
If you're in a status situation, hopefully you can rectify that before you go to something.
Right. And the reason, if for no other reason, then you won't know if you've solved it prior. If you don't fix it first. But on your average patient who's, who you're doing this to, who wasn't seizing to begin with, there's no reason to believe they're gonna start seizing afterwards any more than any other patient would. How many patients do you have on a daily basis who just suddenly start seizing on you for no reason? As long as you're not, and if they do, it's probably because of hypoxia. So, and this is hopefully gonna avoid that.
If you would have to give Versed as first line because they're having seizures, is that okay as a first line sedative versus the ketamine?
I would say yes.
Okay, so you would just use that in place of.
You'd have to double check your protocol because I don't know by heart, but I would say there's no reason you couldn't.
Okay.
We use a lot of it, but.
We probably don't want to do.
Right. And so that's what I'm wondering is like, is it okay to stack them? Ketamine and.
Ketamine and Versed together, I would caution against it. You don't, once you start getting into like polypharmacy, you don't know what hemodynamically could theoretically happen.
Okay.
While neither one of those medications should, on its own, really give you an issue, hemodynamically, I would caution against that.
Okay.
There's no, that said, you can go from one to the other if you have to. I would just be careful about getting a whole lot together. Any other questions?
I know we're slowing down with this, rightfully so. Are there any situations that you would feel we should probably speed the process up? Like you have that bleed that's constantly vomiting, you're not gonna be able to oxygenate them very well other than the cannula.
Yeah, so that would almost fall into a crash airway situation where there's just, if I don't protect this airway, I'm gonna run into all kinds of other issues. Sometimes this is not the right skill to do, sometimes you just need to take an airway. Or if you sit there and go, if I give these, I know I'm gonna kill this patient. You know, there's those patients, you know, they're gonna dump on me. But I would say the uncontrolled airway that I can't see it, they're sick as hell, and again, that may be the patient that you skip this and go right to either a King or a Craig. You know,
Sam, did you have the one that projectile vomited everywhere?
Oh, yeah, yeah.
Sam just did crap back in here lately.
Nice.
I think that was a consideration, but then you did.
It was when after she placed it, strategically placed direct hit on the life pack. After she vomited, she actually started talking to us.
Oh, okay.
She still had a bleed, but she started talking after that, and then we were like, I'm just gonna go to the hospital.
Okay.
So, but it was a consideration because she was unconscious, and then she started vomiting a little bit. You were like, she's gonna choke on it, and you probably knock her out, and then it all came out at one time. And she must have felt better after that.
and the other thing to think about is, so they're vomiting, if I heavily sedate them and paralyze them, I'm taking away the mechanism from which the vomit is coming.
Sure.
You know, so that's something to think about also. Doing this may actually make that better and give you the opportunity